Hello, and thank you for joining this OncLive TV peer exchange. This program features expert panel discussions with a focus on the treatment of non-small cell lung cancer. My name is Dr. Mark Sosinski, and I'm director of the lung cancer section at the University of Pittsburgh and co-director of the lung cancer program. Participating today on our distinguished panel are Dr. Roy Herbst, the Ensign Professor of Medicine, Chief of Medical Oncology, and Associate Director for Translational Research at Yale Comprehensive Cancer Center at the Yale School of Medicine. Dr. Thomas Stinchcomb, Associate Professor for the Thoracic Oncology Program at the UNC Lineberger Comprehensive Cancer Center on the campus of the University of North Carolina, Chapel Hill. Dr. Ann Tsao, Associate Professor, Director of the Mesothelioma Program, and Director of the Thoracic Chemoradiation Program at the University of Texas MD Anderson Cancer Center in Houston, Texas. And Dr. Heather Wakely, Associate Professor of Medicine, Division of Oncology at Stanford University in Stanford, California. Thank you again for joining us. Let's get started. I really want to start today by kind of discussing some of the transformative issues and data we have in non-small cell lung cancer. Non-small cell lung cancer has become a very heterogeneous disease. So what I'd like to do is to ask Dr. Roy Herbst to begin the discussion and talk about the role of molecular testing in the first-line setting of non-small cell lung cancer.
Thanks, Mark. You know, it's really incredible how over the last 20 years, actually really more of the last 10, lung cancer really has become a disease of diseases. You know, every patient has a different type of lung cancer in many cases, different genetic drivers. And what we've learned is that there are certain drivers that appear more frequently that are important to identify early on. And those would be EGFR gene mutations, ALK rearrangements, RAS1 rearrangements, and those are the major three, and then there's several other minor ones. So because of this, and because these tend to occur mostly in the non-squamous lung cancers, I've made it my standard of care to make sure every patient that I see, if possible, is profiled before I begin first-line therapy. In fact, I've recently even begun to test selected squamous cell patients as well, because many of these tumors can have mixed histology, and of course sometimes the pathology reading of histology is wrong. I can tell you that this is so important to do. I'm happy to say that I'm at a tertiary center. I'm seeing more and more physicians around the country sending specimens out. There are a number of different techniques that are used to identify these mutations and rearrangements, and it can make all the difference in the world to a patient because it allows you to offer them, in many cases, an oral agent with much more chance of response with fewer side effects. So mutation testing really has changed the way we look at this disease.
So I think our current guidelines call out routine testing in any adenocarcinoma patient with for EGFR and ALK. But I'd like to ask Ann, should physicians be thinking beyond those two actionable drivers? Are there other things to consider?
Yeah, absolutely, because we now have many targeted agents, the example of ROS1 that Dr. Herbst brought up. We know that ROS1 patients respond beautifully to the crizotinib, also potentially to ceritinib, and so this is a treatment option for these patients that I think is critical. In addition, we now recommend not just testing for those, but in a research setting or also if you do certain things like foundation medicine where you get a genetic panel, we also have other mutations that are very relevant, such as HER2 mutations. There's agents such as afatinib, neratinib that might potentially have efficacy. There are clinical trials that are open for HER2 mutants right now. Also BRAF mutation. Certainly for the V600E, there's data now with dabrafenib potentially having benefit. Certainly KRAS mutation, although we don't have any specific targeted therapies yet, the MEK inhibitors have shown some potential. And it's only a matter of time before we have an agent that will work in the KRAS mutation population. And certainly RET mutations are also very relevant because we obviously have RET inhibitors. They've recently been FDA approved for medullary thyroid cancer. And so we can certainly utilize that also in our disease type for lung cancer.
The lung cancer population does come with a couple of obstacles with regard to getting adequate tissue. Our average age is 70 plus at this year. We have a lot of comorbidities in the smoking population. Roy, can you speak to just kind of the adequacy of biopsy, what docs should be thinking about in terms of their approach?
Right, it is true. We often don't get enough tissue. I'm sure all of us have had the experience of patients referred in, and wherever the patient had their initial biopsy, it might have been a fine needle aspiration, And while oftentimes cell blots are prepared, there might not be enough tissue to do the tests we're talking about now, not to even mention tests for immunotherapy markers that we'll talk about later in the program probably. So you really do we need to let the first responders know that for a lung cancer patient, you need at least a good core biopsy with several good core pulls, or some sort of excisional biopsy, if possible. But really, tissue is critical. The good news is that in some cases, it's so difficult to get these biopsies, certainly in the recurrent setting, that now there are being developed tests that can measure DNA from the serum. And while these are very specific, the sensitivity still needs to be sort of worked out. But I think that's evolving as well, where you can actually take a blood sample and you can actually look and find the DNA and look at the mutations there. But tissue is really critical. And one thing that I hope programs like this will be seen not only by oncologists, but by internists and pulmonologists, people who see many of these patients first, because to do it once the first time is always best.
And then I think the other important thing, and I'd like you to address this, is when we talk about EGFR mutations, the implication might be that they're kind of all created equal. And can you speak just to a little bit about the heterogeneity of the EGFR mutations you may see?
Absolutely. So the EGFR mutations are incredibly important to know specifically what mutation they have, because the response is different depending on whether you have a sensitive mutation or whether you have a non-sensitive mutation. For instance, the deletion exon 19, L858 are the most common EGFR mutations that we know about. Those are very sensitive to the reversible and irreversible EGFR TKIs, tyrosine kinase inhibitors. Now, oftentimes, after they've been on for a period of time with an EGFR tyrosine kinase inhibitor, they can develop an acquired mutation, the T790, which makes them no longer sensitive to these frontline EGFR tyrosine kinase inhibitors. And then there's a whole host like G719 mutations that have shown up where the response has been differential in terms of how well or how long they might get stability of disease on these agents. So it's critical that we know the type of mutation the patient has, and then also when they progress on their frontline therapy, whether they develop an acquired resistant mutation.
I think the take-home message is you got to read the fine print about what the mutation is. Fortunately, 90% of these mutations are either exon 19 or 21, and they're sensitive to EGFR TKIs. But if you fall out, you're in that 10% of the uncommon mutations, you really have to get a better understanding of, is this been shown to be sensitive or resistant, and then act accordingly in that setting. Before we move forward, I want to get kind of a very brief discussion about the role of Veera Strat in this setting. We have some prospective data from the PROS trial. We know Veera Strat is a serum proteomic test done from blood. It's done very quickly, 2 or 3 days. David Carbone developed this test years ago in his lab in trying to differentiate patients who are Veera Strat good that seem to get benefit from an EGFR TKI in the wild type population, and the Veera Strat poor, in which there probably is very little room for an EGFR TKI. And Tom, your thoughts about this particular test?
I occasionally use it, but I think I use it more as a negative selector. If you come back Veera Strat poor, I think that you shouldn't get an EGFR TKI given the efficacy data. I think also it helps sometimes if patients may be a marginal chemotherapy candidate and you get the Veera Strat and they're Veera Strat good, you can give them an EGFR TKI in the second or third line with more confidence that they're going to get some benefit from it.
Heather, any thoughts on?
No, I would echo what Tom's saying. I'm in Northern California, so like half my patients have EGFR mutations, so I don't have that many that don't have a known driver mutation, so it doesn't come up as much in my practice, but I think it's an important tool in that setting. We don't want to be giving patients drugs that are going to have absolutely no benefit, and to be able to do a quick blood test that can help us know if this drug is potentially useful or not, I think is helpful. So I think it's a reasonable tool for that use.